Hello, my name is Rob Melendez, and today I'll be showing a video on the removal of an intumescent cataract. The takeaway pearl for this case is to use ample amount of viscoelastic material. In this first step, I'm placing trypan blue directly into the eye without even placement of an air bubble. Next, I'm replacing the blue dye and displacing that out of the eye simply just with some balanced salt solution. You also see that I also already made limbal relaxing incisions with the rule to correct astigmatism in this case. Next, I'm placing viscoelastic material. In this case, it's specifically viscoat. And this gives me a nice deep chamber, also creates a positive pressure relative to the actual cataract itself. In this next step, I'll create my temporal wound incision. I'll place the Thornton ring on the eye to stabilize the eye. The patient is actually moving around somewhat, and I'm actually rotating the globes just slightly away from me, placing the 2.2 millimeter blade on the surface of the conjunctiva, entering in through the conjunctiva, and creating a two-plane incision with a width of about 2.2 millimeters. I wasn't sure how dense this cataract was going to be, so I increased the width of this wound just slightly. Next, I cut the conjunctiva to limit any formation of chemosis. This next step, I make just a very small capsulotomy, and you can see some liquefied cortex already oozing out of this wound, which suggests that the cataract is under an intense amount of pressure. I'll go in with an anterior chamber cannula, remove some of this material to decompress this intumescent cataract. You'll notice that the capsulorhexis is very small and certainly has that propensity of tearing out in these particular cases. What I should have done at this point, after speaking to one of my senior partners, Dr. Weinstein, was to place more viscoat in at this point to keep that positive pressure there. But I didn't. I extended the capsulorhexis at this point, and then I next use a Utrata forceps to continue the capsulotomy. I'm slowly just turning this around because I'm actually fearful of its sort of tearing outward, and it seems to be tearing just fine. I'm just tearing it around in a counterclockwise fashion, and looks like it's tearing out just evenly. And then you'll see in just a moment that it'll begin to tear out subincisionally, a little too far out that I wanted it to go. So consequently, I, at this point, added more viscoelastic material, in this case viscoat, to create some more space and add some more pressure there. And that's placement of the viscoat. And then I go in and complete the capsulorhexis. I'll go in and grasp it gently, and then I'll tear and I'll pull towards the center of the cataract. And I did have a complete continuous curvilinear capsulorhexis at this stage. I go in and remove the residual anterior capsule there. Next, I'll go in and do a hydrodissection, and actually hydrodissected almost too well to the point that it prolapsed easily. I wasn't trying to prolapse it in this particular case, but I think because the capsulorhexis was just slightly larger than what I had anticipated, it prolapsed quite easily. As I begin with the phaco, I realize that it's a relatively soft cataract, and it's actually coming in quite easily. As you'll see, the vacuum settings on the bottom right portion of the slide, the vacuum settings never exceed 100. So this is me just removing the remainder of the cataract, and it's coming in, actually quite nicely. I'm actually holding the eye with my Calibri forceps because there was a lot of movement in this case. It was done under a topical anesthesia. It's coming in nicely. Because the cataract was prolapsed, I'm a little too close to the edge of the temporal wound, but as you can see, it's coming in quite easily, and I just really have a small cortical fragment there and a cortical shell remaining to be removed. And in the next 5 seconds, I'll finish this here. And you can see the nice red reflex. We're almost done with the removal of the cataract. And there's this subincisional cortical material that was a little difficult to remove with the phaco for some reason. So I actually went in and went in with the reverse cannula, injected fluid to loosen up the cortical material from the bag, and then went back in with the phaco handpiece to remove the small cortical material. And that actually came in quite easily. Then I removed the residual cortical material, which I won't show just for time's sake, really without any difficulties there. Next, I placed Provisc in the bag, and you can see the rhexis subincisionally tore out just a little bit, but it's certainly still continuous, nothing out of the ordinary. But it's larger than what I wanted it to be. Typical capsule rhexis size that I use in most of my cases is about 5.5, 5.75 millimeters. This particular rhexis was probably on the order of about 6.5. At this point, I'm placing in just a wavefront lens made by Alcon. I have no financial interest in any of these products, but the lens goes in nicely. It's opening up there. I'll go in with a Y hook. I stabilize the eye just with my Utrata forceps, just grasping gently to minimize any subconch hemorrhage. And I'll just rotate the lens now that it's in the bag. And you'll see one of the haptics opening up nicely, the distal one. And the proximal haptic, the arm of the haptic is still somewhat adherent to the anterior surface of this IOL. So at this step, I'll go back in with the Y hook, try to get underneath the adherence and just break it free. And you'll see that the haptic starts to open up, but it's still somewhat stuck, and it's opening up slowly, but it's clearly in the bag at this point. But you can see that the haptic hasn't opened up completely. At this point, I'm going in with the handheld Simcoe irrigation aspiration device, removing the viscoat and the residual Provisc material, and everything's going smoothly. But in just a moment, you'll see something occur, which I'll highlight in just a moment. Everything's coming in smoothly, as you can see here. Everything's looking stable and clear. At this point, looks like I've removed most of the viscoat in the anterior chamber. Not really seeing much come through. Then I go underneath the lens just to simply blow some of the residual Provisc that's still underneath there, burp it around, and then aspirate it out. But when I did that, if you notice, the lens itself actually came out of the bag on this left side of the screen. So it's really not securely in the bag. It needs to be in the bag, obviously. The wavefront lenses from Alcon are not designed to be placed in the sulcus. I've had several cases in the past 7 years where, typically in smaller dilated pupil cases, where it appeared that the lens was in the bag, but in reality it wasn't. And as a result, those patients needed either a replacement lens for a lens to be placed in the sulcus. In this case, I do observe that it's not in the bag, at least that one haptic. So I go in, I place a little bit more Provisc to give me some more working room just posterior to the IOL. And that's what I'm doing here, just so I don't inadvertently tear the posterior capsule in an aggressive move. So in this next step, I'm going in with my Y hook, gently placing that haptic in the bag, and as you can see, it goes in nicely, and it's opening up still relatively slowly, but it's actually in the bag. Difficult for your view, but it was clearly in the bag there. And then really from this point forward, everything else went quite well. I'll next just simply show the removal of the Provisc that I placed in, and I'll just go in and simply remove this and make sure that this lens is really securely in the bag. And as I go in, it appears that the lens is doing just fine. Nicely centered. The LRI was already done at the beginning of the case. And really the only thing out of the ordinary with this case, other than the intumescent cataract, was the slightly larger than normal capsulorhexis. So this does conclude the surgery of the removal of an intumescent cataract surgery. I want to thank you for watching this video. And if you have any questions or comments, please feel free to send me an email. And I want to thank you again for watching, and I want to extend a special thanks to my senior partners, Dr. Weinstein and Dr. Ogawa.